We do want to thank you for taking the time to attend our presentation, Meaningful Use Stage 3, How You Can Succeed. Our speaker today is Kay Jackson. Kay is in charge of education and is an advisory manager for iAtric Systems. She's held various product management positions since joining iAtric Systems in 2006, including meaningful use and revenue cycle improvement. She brings over 35 years of experience in the healthcare industry. Now I'd like to turn it over to Kay to get us started.
Thank you so much, Chris, and welcome everyone. I really want to start this presentation by announcing that my meaningful use crystal ball is in the repair shop. So all the comments and information I'm going to provide today are based on my reading and studying, and I don't have any secret weapon to know exactly what's going to end up for stage 3. This is really an overview of the proposed rule, and since I've been a student of meaningful use since December of 2010, nothing CMS does surprises me anymore. We had delays in stage 1, then we had changes in stage 1, then we had the flex rule, now we have changes in stage 2, and both of these last two happened in the middle of a reporting period. So I'm going to start today with an overview of the 2015-2017 proposed changes, and then we'll go into stage 3. I really feel right now the critical issue facing us all, vendors and providers alike, is that stage 2 proposed change and what's going to happen. It's all up in the air. I've been asking my friend at CMS, she's probably going to kill me. I keep asking her every week, when are we going to hear? When are we going to hear? And of course, she can't tell me. But I did read the other day that the proposal for the changes in stage 2 are going to be released probably in August. And that makes perfect CMS sense to me. Provide the rules on the 11th month of the reporting period for 2015. And they do like to, announce rules changes on 5 p.m. on a Friday or right before a holiday. And since there's no holidays in August, it may be Labor Day before we hear. Either way, as soon as we hear, we will be posting information for you. And if you ever want to write and ask me any questions about meaningful use, feel free to do it. My email address is kay.jackson@iatric.com, and I'm happy to help you. So I'm going to go ahead and get started. This is old news now, but I just wanted to remind you that, again, on a Friday, April the 10th is when they announced the proposed rules for stage 2. May not be released till August, but the new NPRM for the changes include retirement of some of the measures, and I think the one that bothers me the most is what they're suggesting for the portal change. So I'm going to talk about the removal of some of these measures, capped out measures. And so I'm going to go ahead and have the list here. This is the ones that CMS proposes to do away with, or as they say, they're capped out, which means they don't think they're valuable anymore. But I feel like a lot of these will still be part of meaningful use. It just means they will no longer be measures that you're reporting on. I've had conversations with a lot of hospitals about these removals on some of these and adding that one that we're going to talk about. But just keep in mind that we're all upset about changing the rules in the middle of the stream. But there's good and bad in that. And the thing I liked about one of the changes was, of course, summary of care. Core 12.1 and 12.3 are removed, and you'll only have to do 12.2. So that may be good news or bad news, depending upon how you look at it. But this information may be captured for other measures. So it's not like they're totally going away. It's just you're not going to have to report on the totals anymore. So the one that I really like the best is the change in the reporting period. So they're proposing a 90-day meaningful use period for 2015, and that's any 90 days. It's not tied to a quarter. And they're expanding the reporting period. They want to get on a calendar year because that's the way the physicians are. So what the proposal states is you'll have any 90 days from October the 1st of 2014 through December the 31st of 2015 to do your reporting. A little funny aside from this, last summer when I was working with a lot of our customers getting ready to attest, and then the flex rule came out and everything, my granddaughter was visiting and she came in and she goes, "Grandma, tell me what you do." And so I was explaining to her as easy as I could to a 6-year-old what meaningful use was. And she sat there and thought a few minutes, and then later she said, Grandma, why don't you stop working on this meaningful, useless stuff and let's go fishing. So whether this is meaningful, useless on some of these changes or good, we're just going to have to adopt and follow the rules. So the change in the portal, this one, they're changing it from greater than 5% to only a single patient having to access, view, download, or transmit in the reporting period. I guess I was more upset about this one because what I really worry about is that we're going to go through 2015, 2016, 2017, not really focusing on patient engagement. And then all of a sudden stage 3 hits us and the proposed is greater than 25%. So I'm really encouraging you, don't let down on your patient engagement efforts. Use this time to look for better ways to reach your patients. Apps that feed data from your portal to other portals or feed data to Apple Health. Because right now I have 5 different portals and I don't even look at any of them. So really encourage your patients to really use that portal to the benefit. Now this is the one that I've been asked the most about since April. Hospitals looked at the 6 published stage 2 menu items before April and they chose the 3 that they wanted to do, and a lot of people did not include ERX. And now they're calling and saying, oh my gosh, I didn't buy it. Do I need to buy it? What's going on? So CMS did have an exclusion. Of course, this is still all proposed, that if you didn't opt for ERX in your 3 menu items that you were going to do, there is an exclusion. Now, what I recommend to everybody is document, document, document. We don't know what they may ask for if you're audited. And so document the 3 that you were going to do, document why you didn't decide to do ERX. I know I've heard lots of different reasons, just so you have that information if you do get audited. So again, that's proposed. Hopefully it'll all pass the way it's been laid out. But Core 12.2, and what can I say about this measure that hasn't already been said? Oh my gosh, this one caused me more gray hair than any of them probably. And this is an example of a measure that CMS proposed or even was a regulation where the industry infrastructure was not in place really to support it. I even had a site call me the other day that their HIE is backing out of the business, and so all of a sudden they're scrambling to find another vendor to do that for them. So some sites had issues with nurses printing. The Core 1.2 could be paper or electronic, and there was a lot of revolt. So your nurses aren't going to have to worry about printing for 12.1 because 12.1, which was greater than 50%, and then 12.3, which was a yes, no. And by the way, the randomizer is no longer valid for that measure. CMS did away with it because 12.3 is going away. So you're just going to have to do the greater than 10%, which is still an issue for a lot of people. Okay, let's go to the next one. How many comments do you think when the NPRM was released in April, you had the time to submit your comments, and I was watching all the comments, and when you get this PowerPoint, this is a hyperlink to the comments where you can read the comments. But I've asked people, I know when I was at the Meditech user group last month, I asked people, what is your guess for the total of comments that had been at that time? The ending up total, now this is for the stage 2 changes, was 1,835 comments. So kind of keep that number in mind when we start talking about how many comments stage 3 got. So we're going to go ahead and talk about stage 3. And there is one thing to mention, that if you are a first-time attester for meaningful use in 2015, you've never attested before, this is your first time, you're going to be under that penalty, CMS has given you till August the 14th to attest. Now, last year, everybody July the 1st. So they've moved it to August the 15th to get everything in place. I don't know if there's anyone on the line that is a first-year attester, but that is just FYI for you. So how many comments? Another quiz. How many comments do you think the stage 3 had? I mentioned that it was 1,835 for stage 2 changes. The stage 3 only got a little less than 1,100 comments. So that tells you that really CMS had more people commenting for the changes on stage 2 than they did for stage 3. So just keep that in mind. And I kind of call it a waiting game. We don't know what's going to be final. I heard November for the release of this stage 3, but we really don't know. And even after they release it, there's going to be some draft certification criteria. This is a really good graphic to show you what's proposed. The draft certification is really, the comment period for that ended May the 29th, and it only got 370 comments. And there was also another NPRM. I think this is the first time that there were 5 NPRMs going on at the same time that really mattered. And that the other NPRM closed on June the 30th, and that's the test script. So that's the testing that your vendors have to pass to be certified for stage 3. Or as CMS is calling the certification for stage 3, they're calling it 2015 certification. Don't ask me why. I have a document I created that has those 5 NPRM if you want me to send you a copy, and I have the link to all the comments for each one of those. But even after the final is released for the final for stage 3 and the NPRM for the test scripts and the criteria, it's going to be a while before the vendors will really be ready. I'm really thinking that it might be the end of next summer before all the vendors have been testing. It is a very long and costly process for vendors to go through that testing process, so it does take a while. So when I read through the rules, and I read through all of them, I did what I called a kind of a recap of what I thought, and just my recap was 27 pages. So I've kind of used some of that recap to talk about what I'm going to talk about today. And just keep in mind that, again, it's proposed. We don't know what the final is till it comes out. So the first thing I wanted you to know about stage 3 is that it's proposed. You're going to hear me say that probably 10 more times. The final regulations aren't due until later this year, or even then we don't know. And I just kind of put a little recap for you. The thing that I think grabbed my attention the most for stage 3 is the method. You know, the all-ED or observation service method is totally left out. So as I go through here, I'm going to kind of tell you what they're saying is going to be your population. But think about it. When you had the all-ED or the observation service method, your denominator was based on a reduced patient population. Now that's going to be all patients, your denominator is going to be greater, which means your numerator is going to be have to be higher to really meet the measure. So the other thing I thought was interesting is that hospitals and physicians are going to have the same 8 objectives. There's no more core and menu anymore. They're gone. So that's just kind of the keep in mind that that's where we're going with stage 3 of meaningful use. Transition of care, again, my least favorite measure. So it's going to be all discharges from an inpatient setting are considered part of transition of care. So I had a lot of people say, what about patients that died? What about patients that were going to a jail? All of these things that there's no way you can provide a transition of care. So what CMS has said is all discharges are going to be included. And then for transitions from an emergency department of an eligible hospital or CAH'S, you must count any discharge where follow-up care is rendered by an authorized provider. I don't know how you're going to keep track of that. We're all going to have to really think about how are you going to keep track of whether they had follow-up care or not from that ED visit. And regardless of how complete the information is, so if the patient's leaving, you got to send that CCD. Even if all the information's not there, you still need to send it. So that's the proposed transition of care measure. And let's go on to the next one here. And stage 3 is going to bring enormous change. I read through the regs, and it just kept hitting me at the day-to-day precedented amount, the clinical data, no, all of your payers, whether it's Medicare or not, standardized data. And of course, the ACOs need that to really do the best care they can for their reimbursement. And I thought this was interesting that $45 billion annually is paid by Medicare. This is the estimate for medical care that was not medically necessary or accepted documentation. So be prepared to really have to provide more information to CMS for payment of claims, because they feel like they're paying, claims that are not really valid. And that's why I read a lot. Like I said, over 100 times in the proposed rule, they kept talking about the electronic submission of medical documentation, or as I'm hearing it called, you know, information without a stamp, how you're going to be providing that information to CMS about your patient information. They say it's going to reduce costs for the federal providers, and so, of course, private payers are also going to use this. And I really understand there's still some problems with esMD, so if you're a member of our blog or our forum, I'll keep putting information out there about what's going on with this and very important information of how we're going to get that data to them to actually reduce our claims and pay our claims. So I thought I'd give you some key dates. Keep in mind that now they changed the reporting period where we normally had to attest in October or November. If it goes through December, you'll have till February the 29th to attest, where you get an extra day because it's leap year. But here are the key dates to remember going forward. So for 2017, a full year, it's voluntary for stage 3. I have not talked to anybody that plans on doing stage 3 in 2017. But there's your attestation date. So 2018, all providers, regardless of your stage, have to do stage 3. So say you normally in 2018 would have been stage 2, it doesn't make any difference. All providers will be attesting to the same stage. All providers will be attesting to the same measures, and the attestation period is the same for the physicians and the hospital. So we just hope that their attestation page doesn't crash. They're saying now that stage 3 is going to end. There's not going to be a stage 4 like they had alluded to before. And the attestation period for the last reporting period will be January the 1st of 2020 to February the 28th of 2020. But from what I'm reading, it appears we may still be having to report measures. They're thinking of some way to continue this, but it won't be called meaningful use. So just keep that in mind, that these measures may be still reported. We just don't know yet. There are some payment adjustment and hardships that are included in that regulation. I've got them here for you, of course, still proposed, but there doesn't seem to be as much leeway as there has been. The certification requirements, I kind of mentioned it, that for the 2018 stage 3, or if you do it in 2017, it's going to be the 2015 edition certification. So everybody right now has the 2014, all your vendors that you're using to attest are 2014 certified. CMS says that's fine until you start doing stage 3. So you'll be using that 2014 certified software till you start stage 3. Now they've added API, and API is going to have to be certified, and testing bodies have new and revised conduct. What we saw talking to different certification bodies, they weren't all following the same regulations. So CMS has said, look, everybody has to test the same way. Everybody has to interpret it the same way. So I think that's a good thing, because now everybody will be, all the vendors will be under the same requirement for certification. So you know, if you got a certified vendor, they had to meet the same certification requirements as any testing body that might be different. They have some new terms. The ONC HIT certification program is now going to be the ONC Health IT certification program. And what I believe is they're leaning towards, or they're moving towards, no more meaningful use, but this is what our model is going to be going forward. So let's talk about the proposed objectives. For number 1, and remember, no more core and menu, they're called proposed objective. The first one is protect health information that we've had in stage 1 and stage 2. It's a yes/no measure. They have expanded the explanation, kind of tightened up what you could almost read into it before. They put administrative safeguards in place, and I think one of the biggest changes, the risk analysis has to be reviewed each year within that 365-day reporting period. But they've also said that you have to do a new one upon upgrade to a new edition of certified EHR technology, and again, continue that review and update. If you find problems, document them. All the sites that I've been involved in, when they've been audited, that's one of the things the auditors really look for. What is your ongoing correction to any problems that you've discovered in your assessment? I put these up here because I really want to draw your attention to some of the changes. There were several changes last year in the security risks for stage 2. So use these tools, go through them, make sure that you've included all of the changes that were put into place last year. Objective 2, electronic prescriptions, or prescribing. It's going to be greater than 80% They've defined what permissible prescriptions are. And as you know, many of the states now have legalized controlled substances being included in electronic prescribing, which I think is really valuable. You know, that electronic prescription is going to go electronic to that drugstore. No way that anyone can alter that prescription. So I think that's a good thing. You'll notice as I go through some of these that are numerator denominator, I'll have the median rate. The median rate is what CMS said was the median rate they found for stage 2 attesting hospitals. So what they're saying is for e-prescribing, what they saw in 2014 was a median rate percent of 53% average. So they decided that greater than 80% was where they were going to move this measure. They really jumped it up. And again, over-the-counter drugs aren't included. There are some exclusions. We'll see what the final is. But what I thought was interesting, too, was stage 3 will only be new and changed prescription. So again, how are we going to trail whether that's a new or changed when we're counting that for meaningful use? And then the formulary, if it's unavailable, you can still count. So that's the objective for stage 2 for electronic prescriptions or prescribing. The proposed for objective 3 is your clinical decision support, which again we've had since stage 1. Stage 2 changed a little, but there's going to be 2 yes-no measures. So again, we've got some sub-measures like we had first introduced in stage 2. They've explained more what they mean by relevant point of care. They've actually explained what type of clinical decision support that they will be allowed under the measure. And they've implemented clinical decision support interventions which relate to care quality goals and related CQM outcomes. The only exclusion for clinical decision support is for EPs as it stands right now. So the measure 1 is you must implement 5 clinical decision support rules, and they have to be related to 4 or more CQMs, and you have to do it at a relevant point of care. And again, I said they've defined what they mean by relevant point of care, and you have to do it for the entire EHR reporting period. If you have absent 4 CQMs that are related, then you have to pick a high priority health condition. So again, they've really given us more information of what they want you to track for this clinical decision support. Measure 2 is you must enable and implement functionary for drug-drug and drug allergy interaction. So remember, that used to be in another stage 2 and some stage 1. So this is where they've incorporated measures that used to be required as part of a yes-no measure. So you still have to do them because they're part of this measure. So 4, CPOE. So of course we had that in stage 1 just for meds, and then in stage 2 it expanded. So there's 3 measures to track, just like in stage 2. But stage 3 they expanded to include diagnostic imaging. So that can give you a few more that you're going to be tracking. But the orders entered by any licensed healthcare professional, or now they've added credentialed medical assistant. And what they also say is it should be used the first time the order becomes part of the patient's medical record, and before any action is taken on the order, the CPOE must have been performed. And still, protocol and standard orders can be excluded from the measure. So measure 1, currently it's 60%. For stage 3, it's going to be greater than 80%. And I remind everybody, CMS, I guess, doesn't know how to do decimals, so CMS only accepts whole numbers. So if you have a score of 80.1, that's not going to count it. It has to be a whole number. The median score for the people that attested in 2014 to stage 2 was 93%, so they've again bumped that up to 80%. So that's measure 1. Measure 2 is the labs. The median score was 80%. Currently it's 30, so I guess that's why they said, okay, we're going to make this one a 60%. And 3 is the diagnostic imaging. The median score on this one, again, was 83%, and the requirement for stage 2 is 80. So it kind of, it was 30. So it kind of gives you where they looked at the scores. But again, how many sites really attested to stage 2? I think it's a small percent that they've based all changes off of the small percent that actually attested in 2014 to stage 2. Objective 5 is patient electronic access to information. There's going to be 2 measures to track. There's some exclusions, unique patient measure, and they've added this API. It's a new functionality that really supports data access and patient exchange. And, you know, I asked some of the smart people in our company, what is API? And so this is what they told me. It's a set of programming instructions that is web-based. So when you create a web tool, the software company releases the API so other software developers can access that information and use it. And this is how they explained it to Kay. They said, Kay, it's kind of like Amazon, because I know I'm a huge Amazon user. It's where Amazon has that API that allows a third-party website can post directly to Amazon products. You know, like you can see buy now or updated prices. So it allows a third party to come in and give more information. So API is one of the changes for stage 3. And patients will have to be able to collect their health information from multiple providers and potentially incorporate all to their health information to a single portal. So, you know, Apple came out with Apple Health where you can put all your information in one location. So it'll be interesting to see how Apple Health grows with this new regulation, again, proposed. So, again, API is new. If the provider elects to implement an API, the provider would need to enable the API functionality, provide patients with detailed instructions on how to authenticate, and provide supplemental information on the available applications which really leverage the API. But CMS also has said, and I'll go over in a minute, that there's options for you continue to use your portal or use API. So the first measure, greater than 80%, that you provide access to patients to view, download, transmit. And you remember the early part of stage 2, everybody was misunderstanding what provide access meant. Some people said, oh, I just have to give them a brochure. What CMS came back and said, provide access means you've given that patient everything they need to be able to create their account. And remember, too, and that's why I put demo recall or any way you want. This is a historical measure. So if you gave patients access to the portal, say, March of 2014, and now you're in your reporting year for 2017, and that patient comes back, I asked CMS, having writing from CMS, yes, you can count forward any patients that you've provided access if they come back in later years or later reporting periods. So use a way that you can track that ongoing, because that's a historical measure. Right now, it's greater than 50%. Most people met it. I couldn't find any medians for stage 2 of what that was. At CMS based this greater than 80%. It wasn't in the regulation. The other thing is, and I think this is going to be the hardest for the physicians right now, the physicians have 4 business days. So the weekends don't count for them to get their information into the portal. And hospitals had within 48 hours. It's going to now be 24 hours. So huge change for the physician, like a 50% change for the hospitals. This is a quote from CMS, and I had to read it 3 times to make sure I was reading it right. It says, the objective does not require the provider to make extraordinary efforts to assist patients or access of the information, but the provider must inform patients of these options and provide significant guidance so that the patient could leverage the access. And I said, what? How else are you going to reach that percentage if you're not physically helping a lot of your patients access the portal? So I thought that extraordinary effort was very fun coming from CMS. And I always say this in any webcast, if you look at the people that are in charge of meaningful use, if you look on LinkedIn at their bios, very few have ever worked in a hospital. One actually was an intern at eBay before he went to work for the government. So a lot of times they don't understand some of the things that you have to go through as a provider to meet some of these measures. This is for Objective 5, I mentioned that there's 3 options. You can provide access with a portal. You can provide access with an ONC-certified API. So if you're going to have a vendor that has an API, again, it has to be certified. Of course, if you have a portal vendor, they'll have to be recertified for stage 3. Or you can provide access to an ONC-certified API that can be used by a third-party application or device to provide patients or their representatives access. So it'll be interesting to see where that falls out, who moves from a portal to an API or who stays with a portal, or who uses a combination. So Objective 5, Measure 2, greater than 30% of your patients use clinically relevant information from the cert to identify patient-specific educational resources and provide electronic access to those materials. So another one's going to be kind of tricky to count, but you've got to provide greater than 30% of your patients that electronic access to relevant information. So right now in stage 2, patient education was core 10 and you were only required to provide 10%. Now you're going to have to provide greater than 35% and it has to be electronic. Big change. The other thing is that and I'm glad they've got this in the rule, that you may withhold from online disclosure any information either prohibited by state, federal, or local, or any information that may cause significant harm. And this is one of the things the physicians had a hard time dealing with, the patient getting information before they had a chance to tell the patient. So they do have that in the proposal. Proposal Objective 6, coordination of care through patient engagement. Again, remember I said don't let down your guard on patient engagement because it's going to come back at us in stage 3. There's going to be 3 measures and the providers must report on all 3, but you only have to meet 2. Really strange how they did it this time. There's some exclusions, unique patient measure, and they've removed paper communication from this measure. So the first one is greater than 25% of your patients have to view, download, or transmit. We're all having a hard time doing it right now at 5. And what was interesting is even CMS said the median score of those reporting was 11% for stage 2. So they're upping it more than double to 25%. And again, they're going to have the 2 options, whether you use a portal or the API. And I just still cannot understand why they keep throwing in things. You know, we're barely meeting with the portal. We're trying to get patients to get on the portal, and now we're going to give them, oh, there's another way now you can get on. The other Objective 6 measure 2, and remember you only have to meet 2 of these 3, is greater than 35% a secure message was sent using electronic messaging function, excuse me, of cert or to the patient or in response to a secure message sent by the patient. But the provider must respond. So you're going to have to track, did you get this message? Did you respond to it? Okay, you know, greater than 35%. There's some of these I'm just really going to have to think about how we can track effectively and correctly. For the provider-patient situation for Measure 2, we propose to include the measure numerator situations where providers communicate with other care team members using secure messaging if the patient is engaged in the message and has the ability to become an active participant. So again, we're going to have to really decide how are we going to know if there's an interchange of information and that patient is involved or engaged. And I really want to know the definition of what CMS is engaged. What type of communication is excluded? I was really excited when I first started reading it. I thought, oh my gosh, when I was a director of business office and admitting, there were so many messages we could send our patients. Now we can do it electronically and it'll help. But they've noted that messages with a content exclusively related to billing question, appointment scheduling, or other administrative subjects cannot be included in the numerator. So how are you going to exclude those type of messages from the ones that really count? Going to be a fun time for us. The proposed Measure 3, and again, you only have to do 2 of these, is greater than 50% of non-clinical information is incorporated into your EHR, and that's for inpatients and ED patients. So incorporating that information into the EHR. This may be one that people don't do. I don't know. It's going to be interesting to see what people elect to do. Number 7, health information exchange, my least favorite in stage 2. It's probably going to be my least favorite for stage 3, but there's 3 measures. You must report on all 3, but you only have to meet 2. There's some exclusions. Stage 3 must include the common clinical data sets, and you also have to include the device identifier, the UDI, for implantable medical devices. So the big change to summary of care, the purpose of this objective is to ensure a summary of care record is transmitted or electronically captured and incorporated into the HR for patients seeking care among different providers in the care continuum, and to encourage reconciliation of health information. I tell you, I don't know that I've talked to any hospital where they've sent a CCD and that receiving provider even opened it, yet alone incorporated it into their EHR. So it's going to be a struggle for us to reach those numbers when we're having to depend. It's kind of like we have to depend on the patient to log on to the portal. Now we're going to have to depend on those transferring providers to incorporate that into their record. The referral definition are cases where one provider refers a patient to another provider, but the referring provider also continues to provide care for the patient. So how are we going to know if they're continuing to provide care for the patient? The patient comes in your ED, and are you going to know? You may never see that patient again. Stage 3 changed the inclusion of transition of care referrals in which the recipient provider may already have access to medical records maintained in the referring provider's cert as long as the providers have different billing entities. So that was a good change that they announced. Proposal 7, Measure 1, greater than 50% of the patients create a summary of care in electronic exchange. So you've got to create that summary of care for greater than 50% of your inpatients and your EDA patients and exchange it. Stage 2 requirement, the no more paper is gone. Like I said, you're not going to have that opportunity to include paper with that total. And it allows just clinically relevant lab tests. You know, I asked CMS so many times, I said, everybody I'm talking to, the receiving provider doesn't want all that lab tests. They don't want lab. The patient had been in for 3 weeks. They don't want all that lab. They just want the recent. So they are saying clinically relevant lab tests. So to me, maybe just a lab test for the last 24 hours. You're going to have to make that decision, but it's provider discretion where beneficial. So again, what's the final going to tell us? Objective 7, Measure 2, greater than 40% of transition referrals incorporated into the EHR. I just don't know how this is going to work. It's going to be interesting to see. You've got to incorporate 40% into your EHR. And do you really want that? And who's going to be doing the review and making sure it happens, and how are you going to count it? Measure 3 is greater than 80% where provider has never encountered the patient to perform clinical information. So you're taking that CCD into your system. You've never seen that patient before. You're at that time going to have to do medication, medication allergy, and problem list reconciliation. So staff members going to have to be doing that. How are you going to track that that was performed? Objective 8. I've got to get away from saying measure. Public health and clinical data registry reporting. It's a yes/no measure. Hospitals have to do 4. Physicians only have to do 3. It's really encouraging the communication that should exist between the providers and the health agencies. There's some exclusion. They're removing ongoing submission. Remember that was in the regs, and now they're replacing it with active engagement. So that means you're going to have to continue actively engaging and sending the information to those health registries. So the first one, you have 3 options. Registration, so if you've never been involved with that registry, you have to submit your data. You have to complete within 60 days of the start of the reporting period. So reporting period starts in January. You've never done business with this this health provider. You're going to have to do your application within 60 days of the start of your reporting period. If you're already registered, then you're going to option 2. And option 2 is testing and validation. Providers must respond anytime they get a notice back that there's something wrong with their information. They have to respond within 30 days. Failure to respond twice with a reporting period would mean you do not meet this measure, which means you fail stage 3. And the option 3 is production. Completed testing and validation and electronically submitting production data to the public health registries or clinical data registries. So that's where most everybody will probably end up. I put this little grid in there just to kind of let you know these are the 6. Again, you must do 4 of them. We've already been doing 3 of them, so you'll just add 1 more. CQMs. Oh my gosh, I have asked CMS so many questions about CQMs recently. You know, there's 16 required right now. They're trying to align the CQMs with the IQR and PQS program. CMS encourages you to submit your eCQMs for 2017. They've said in several webcasts that it's not going to be mandatory, so I've written to them asking them if that still holds true, and they go, well, maybe, we don't know yet because none of the final rules are out yet. So they kind of tiptoe back on some of the things they've said in webcasts. So watch our iForm or our blog for when we get the final from CMS on what they're really going to do. But they're saying right now, in January of 2018, you must submit electronic CQMs. Right now they said, okay, 15, 16, 17, you can do them manually, but 18, you're going to have to do eCQMs. They did say that the CQM certification for your vendor won't be required until the reporting period of 2018. So the current your version that your vendor has certified now. But between now and 2017, CQM may attest with core measures, and any version of the CQMs is okay. But keep in mind, this could change. You know how CMS does the changes. I just gave you some resource pages, some things that I thought might, might help you. Let me go back. And what I wanted to say on this one, Sorry about that. I closed it out too soon. What I wanted to say about these resources that I think is really important is that there are several that you need to read and study, but what I want to remind everybody, again, these are resources. You need to interpret the regulations the way you do. I was just on a vendor webcast with CMS, and I was hearing them say that there's a lot of miscommunication about ICD-10, what they really want you to do. The same thing holds true for meaningful use. I've heard vendors say things that I know CMS was contrary to what CMS said. You really need to make sure that what you're understanding these final regulations is your interpretation. Have that documented. You know, I really think that CMS, again, is going away from fee-based to quality-based to value-based, and they just announced today that as of today, July 16th, the Hospital Compare website has been updated. Listen to what they're going towards. They're going towards quality, quality, quality. They say that they have timely and effective care measures are updated, readmission, complication, death, 30-day outcomes. All of that has been updated now on the Hospital Compare website, even the HCAH'S scores. So as of today, your patients that are going to that Hospital Compare are going to see a lot of additional information. They did announce today that they've suspended SCIP INF4, the cardiac surgery patients with controlled postoperative blood glucose. And on the Hospital Compare website, they're just going to show that the data is suppressed. So again, all that we're going towards is quality. And I always remind everybody that not all of your quality measures are ones you reported, like your 30-day readmits. That's all based on your time status. So you really need to monitor that and make sure you've got good information or why you're getting penalized, because about half of the hospitals got penalized last year for the readmits. So as your team moves towards the stage 2 changes or the stage 3, I think the most important thing is we're working to improve the care to our patients. Remember that sepsis starts October the 1st for IQR. How are you tracking that? Are you going to use analytics? Analytics is going to be a key word that you're going to hear excuse me, going forward. You've got to know what you don't know now. And some of the meaningful use helps that we provide, we have an I-form. If you want to sign up, let me know. I think as of this morning, I had 1,787 articles out there. We've also started a meaningful use blog. We offer meaningful use gap analysis, mock audits, patient engagement assessments, and if you need a team leader for meaningful use, we've got a lot of professional services that we can offer in addition to our application. So, Chris, I'm going to send it back to you. Have there been any questions that have come through chat that I can ask? And if I don't know the answer, we'll get you the answer and we'll let everyone know the answer. So, Chris, any questions?
There have been none. If you do have a question, just enter it in the questions pane of your control panel, just as a reminder.
Yeah, and you may think of something down the road. You know, you can always email me, k.jackson@iatric.com. I really feel fortunate that one of the key players in meaningful use, Beth Myers, we've become very good friends over the last few years, and I go only to Beth to ask any information. You probably have heard her speak in a lot of the CMS webcasts. Her name is even on the NPRMs, so she's who we ask if we have any questions. So anything you want me to ask, or I may have already asked her, I can share her answer. And she said just take her emails, put it in your documentation as proof of why you did that particular measure the way she said that it was the intent for CMS.